MBBS and my dear colleagues, a very warm good morning to one and all. And today we are privileged and happy to have Dr. Sushma Bhatnagar ma'am. She is the head and professor and head of Department of Oncologist and Palliative Care, AIMS New Delhi. And with us, in the name of the whole ED family, I welcome ma'am to our presentation. Today I would like to start my discussion with a clinical based scenario. Dr. Sanit, can you please read out the scenario for us?
There is a 6-year-old female patient and no case of carcinoma of post proctological study with bilateral examination and hypothesis consultation with peritoneal unit, momental and eccentric metastasis. On chemotherapy, gemcitabine, carboplatin. Last chemotherapy on 6. Okay, 20. She has resolved complete fever last 3 days and short fever to 1 day.
Here we have the primary survey of the patient.
The primary survey is not rarely taken, and the main circulation is 70. The room saturation of 79%. The circulation got the blood pressure is 50 millimeters in mercury, the pulse rate of 130 per minute.
Dr. Satya Prakash, how would you stabilize the patient? Here we have the initial venous blood gas picture of the patient. So, Dr. Archana ma'am, can you please evaluate the initial venous blood gas? So, how would you like to proceed further, ma'am, based on the initial venous blood gas findings and the primary survey, and also by evaluating the clinical background of the patient? Will you go for aggressive care or will you consider anything else? So, coming to my topic proper, today I will be dealing with palliative care in the emergency department, and also I will be discussing briefly about the guidelines for end of life care. So, today my moderator is Professor Praveen Agarwal sir, and myself Dr. Vaishnavi, Junior Resident, Department of Emergency. So, I will be dealing with these objectives in my presentation. First, I will cover the definition of palliative care, and then I will go for descriptions of palliative care in emergency department and how to assess the need for palliative care in a patient presenting to the emergency department, and what is hospice care, and I'll be considering the symptom and treatment management in any patient presenting to the emergency department about palliative care. And I'll be covering guidelines for end of life care and ICMR guidelines for remote attendant patient and disposition part of palliative care patient from the emergency. So, coming to the 2020 WHO definition of palliative care. Palliative care is an approach that improves the quality of life of patients, both adults and children, and their families who are facing problems associated with life-threatening illness. It prevents and relieves suffering through the early identification, correct assessment, and treatment of pain and other problems, whether physical, psychosocial, or spiritual. So this has put in 2020 and 2021 में IACF International Association of Hospice and Palliative Care put forth a new modified definition of WHO. That is, palliative care is the active holistic care of individuals across all ages with serious health-related suffering due to severe illness and especially of those near the end of life. It aims to improve the quality of life of patients, their families, and their caregivers also. So coming to the description of palliative care in emergency. So who are only candidates in whom we can initiate palliative care from the emergency? Basically, they are any patients with serious, potentially life-threatening illness and their families. What is the purpose of initiating palliative care in emergency? As I briefly said in the definition part only, it is for relief of symptoms from potentially curable conditions in the presence of chronic devastating diseases. When the standard treatment impedes the patient's remaining quality of life to incurable conditions, such as in advanced dementia or stage 4 heart failure. When will you initiate this palliative care? So after a lifespan limiting prognosis has been defined, or when requested by the patients and their families to enhance the patient's quality of life. Where we can initiate this palliative care? So it is basically in the ED and every other setting in which the patient receives care or wishes to receive care, such as at home. Then ultimately, why? Why we are initiating this? Because the relief of suffering is the primary goal of medicine, and there are few places with greater patient suffering than in that. How will you initiate this? So basically, we have to counsel the patient and their family regarding the diagnosis, prognosis, and effectiveness of the potential therapy. And if they have decided, then a team consisting of at least one doctor and nurse provides care measures. And we should have a consultation with the palliative care service. And the ultimate question: who can decide to initiate palliative care? The patient can decide, and provided he or she retain decision-making capacity, or the surrogate decision maker, the legally appointed durable power of attorney for healthcare, or closest family relative who speak for the patient can also decide for initiation of palliative care. So, for any patient who has presented to the emergency medicine, how do we assess the need for palliative care? So, R.D. Oliveira et al. Conducted a study in palliative medicine in the emergency department, symptom control and aggressive care. According to this study, palliative care need was defined as the presence of terminality criteria according to the National Hospice Organization terminality criteria, or if more than two comorbidities accounted in the Charlson comorbidity index were present at the time of admission to the ED. So I'll be dealing with these two criteria in my next slide. This is National Hospice Organization terminality criteria. According to this, only any one of these criteria should be present at the time of admission to assess the need for palliative care. So patient can be have any inoperable metastatic cancer, or congestive heart failure symptoms at rest, or ejection fraction less than 20%, or de novo dysrhythmia, etc. These are the most common findings we have come across in the cardiovascular disease. And coming to the pulmonary disease part, patient could have dyspnea at rest and symptoms or signs of congestive heart failure, and a saturation of less than 88%, and a partial pressure of carbon dioxide more than 50 ml. And in patients with dementia, if they have inability to walk, or sphincter incontinence, or with speech less than 6 understandable words, etc., and patient with hepatic disease, will come across mainly through refractory ascites, spontaneous bacterial peritonitis, and jaundice, and a prothrombin time of 5 seconds over the time. And renal disease patients with a creatinine clearance of less than 15 ml per minute, or serum creatinine more than 6 milliliter per deciliter, and frailty syndrome patients who are confined to the bed or home and decubitus ulcer or albumin less than 2.5 gram per deciliter. So I repeat once again, any one of these criteria is present at the time of the admission, the patient can be considered for palliative care. So coming to the next criteria, that is Charlson's comorbidity index. So according to this criteria, more than two comorbidities should be present at the time of presentation to the ED. In this, we have connective disease and AIDS, gastric ulcer disease, and mild to severe liver disease, and moderate to severe renal disease, and cancers like metastatic solid tumors, leukemia, lymphomas, and COPD, and neurological diseases like cerebrovascular accidents, dementia, hemiplegia, and cardiovascular disease. We have myocardial infarction, congestive heart failure, and diabetes with or without enterocarditis. So once again, more than two comorbidities criteria should be present at the time of admissions according to Charleston's comorbidity index. So next I'll be covering hospice care. What do you mean by hospice care? Can anyone tell me on palliative? What do you mean by hospice care? Voluntarily, anyone? These both are same, hospice and palliative care. I'll be showing a diagram that itself clearly mentions what is palliative care and what is hospice. So from this you can understand that hospice care is a part of palliative care only. It's a comprehensive program of palliative treatment that is appropriate when the patient with chronic, progressive and eventually fatal illness are determined to have a life expectancy of 6 months or less. So, comparing both, palliative care can be offered at any time during the disease course regardless of prognosis. But hospice care is started only when the patient has expected prognosis of less than 6 months. And palliative care patients still have access to all the treatment. But hospice care is started once the cessation of all disease-directed therapy. These are the model of the palliative care, and the first one is the old model. The report diagram is the old model, and here we can see once the diagnosis has been made. Initially, we started disease-directed therapy, and once the disease-directed therapy has ended, then only we started palliative care at that time in the old model, and followed by hospice care. But in the new model, you can see once the diagnosis has been made, the disease-directed care and the palliative care is initiated simultaneously, and followed by we have hospice care. Coming to the treatment and symptom management of any patient who presented to the emergency department, palliative. So, palliative care patients, the distressing symptoms should be treated first, including pain, dyspnea, and vomiting. Pain is the most common reason among palliative patients for seeking care, followed by dyspnea and vomiting. How do you assess pain? Dr. Debashish, can you please tell how do we assess the pain scales of the patient? Thank you, Debashish. So we have various pain scales for assessing pains in a normal patient. So how do you assess pain in a patient with advanced dementia? Do we have a separate pain scale for that? Yes, we cannot assess pain in an advanced dementia with patients with these pain scales. We have another separate scale called the Painard scale, that is pain assessment in advanced dementia patients. So in this criteria, we have 5 things. That's first one is based upon the breathing, that is independent of the vocalization, and we have negative vocalization. And the third thing is facial expression and body language and consolability. So it is scored categorized into score 0 to 2, and the maximum score is around 10. So a score of 7 to 10 is considered as severe pain in this patient. So I'll be showing a video about how to assess the Painard scoring system in later towards the end of my presentation. So how do we control the pain? So biggest obstacle to aggressive pain management with opioids has been the fear of respiratory depression. So a patient can be safely dosed and redosed until the pain is palliated as long as we monitor the patient's level of consciousness. So these are the 3 common drugs we use in the emergency department for pain control. Morphine can be used at a dose of 2 to 6 milligrams IV and 10 milligrams IM or subcutaneously, and 10 to 50 milligrams per oral tablet. And fentanyl injection can also be used 50 to 100 micrograms IV or 100 micrograms nasal sprays in one nostril or 100 microgram buccal microphone tablet. And tramadol also we most commonly use. Its dose we will know 50 to 100 milligrams. So the next common symptom the patient presents is dyspnea. So we have to identify the cause of dyspnea and treat the underlying pathology. So when treating dyspnea in an opioid naive patient, start with morphine at a dose of 0.05 milligram per kg and monitor for sedation and hypoventilation. So the goal is when we are giving morphine is to maintain a respiratory rate of at least 10 to 12 breaths per minute. So the next symptom is nausea and vomiting. So for the underlying cause of nausea can help identify the class of anti-emetic drug most likely to be therapeutic. For example, chemotherapy-induced nausea can be better controlled with modern symptoms, and dexamethasone can also be used. And nausea and vomiting caused by increased intracranial pressure and bowel obstruction from the cancer can be better controlled with steroids. And for refractory nausea in the palliative care setting can be better managed with haloperidol and propofol. Metoclopramide can be considered for diabetic gastroparesis or compression of the stomach due to humor or acidity. Remember that metoclopramide is absolutely contraindicated in complete industrial. So coming to constipation, this is also a most common symptom seen in the patients as a side effect of opioids. So patients on opioids needs a concurrent bowel regimen such as cosmetic agents like polyethylene glycol or stimulant lactate. And the last but not least specific, agitation. The patient with a terminal illness may become agitated with or without belief. The causes of this agitation could be multifactorial. For example, it could be pain or effect of the terminal illness, or anxiety, or terminal restlessness, or breathlessness, and mental anguish. So it can be better managed with antipsychotics like haloperidol, or anxiolytics like methadone, or opioids like morphine. Coming to the ICMR consensus guidelines on do not attempt resuscitation. So we all know that CPR is an emergency procedure performed in an attempt to revive patients suffering from cardiac or respiratory arrest. So in certain situations, providing CPR is likely to increase the suffering of the patients who have serious terminal illness and without the prospect of a reasonable quality of life, even if they are revived. So to take a decision about do not attempt resuscitation, what we have to do is we have to communicate with the patient and the relatives. So provide patients and their relatives adequate information on the disease or medical condition. The poor chances of meaningful survival or worsened quality of life enable them to understand the likely benefit or potential harm of CPR in case it is required. Do not attempt resuscitation relate to CPR only and its limited value in certain situations and not to other forms of treatment. For example, we can consider hydrotropic support for the patient. Whenever the treating physician is in doubt on whether to perform CPR, do not attempt resuscitation or not, CPR should be performed as the default option. What is the purpose of DNR? It is basically to help the treating physician and patient or surrogate in preserving the dignity in death. And it avoids prolonged suffering to the patient through non-beneficial CPR while continuing to provide other potentially curative and supportive care. Coming to the guidelines for end-of-life care by AIMS. A good death is the right of every patient. A good death is the right of every dying patient. And a study has conducted in 2015, that is a worldwide survey in UK in 2015 about the quality of the death in patients. So India ranked 67th among the 80 countries. So that itself means that the quality of death in India is very poor. So that led to the initiation of these guidelines for end-of-life care by AIMS and by various expertise from various disciplines. Our HOD sir and Sushma ma'am are part of these guidelines. These guidelines consist of basically 7 steps. The first step is the recognition of the futility of further management. So the futility of further management has to be decided primarily by the primary treating physician only. For example, if the patient is having any malignancy and is a follow-up case of medical oncology, then the futility of further management has to be decided by the medical oncologist. Or the patient is a follow-up case of COPD under pulmonology, then the futility of further management has to be decided by the pulmonologist. So it has some criteria, that general criteria for recognition of futility. That are the life expectancy expected to be in days to be any condition where clinician predict a very low chance of meaningful survival and purposeful life, or post-cardiac arrest status with poor neurological outcome, or brain dead patients who are not suitable for organ donation. So these are all the general criteria. So the next step is clinician's consensus on futility of further management. So once the primary physician has recognized the futility of the further management, the next step is once other clinician of the same concerned specialty not directly involved in the care of the patient should also mention that there is futility of further management. So once the consensus has been reached, there should be detailed documentation justifying the futility decision. After the consensus on futility of further management has been prepared, a mandatory referral has to be made to the palliative care. So the third step is so after once the futility has been recognized and the clinician's consent has also made, obviously the next step is to counsel the patient and their relative regarding that. So for this, the third very most important step is early and detailed explanation of prognosis with proper communication and documentation of disclosures by patients and your family members for withholding life support. So while the physician should explain the patient and the family members together in a meeting, and he should emphasize on the following things like short life expectancy of the patient and the burden versus benefit of the aggressive management. Or he should also provide an option like end of life care as an alternative only, and change of goals of treatment from cure to care. And he should explain the symptoms expected in a last few days or hours and their comfort strategy. And the next fourth step in the guidelines of end of life care is assessment before initiation of end of life care. So there should be continuous assessment of daily supportive care plans like vitals and whatever treatments we are providing for the last few days, or documentation of daily progress. And fifth step is continuous assessment of daily supportive care plan. And sixth step is documentation of daily progress. And seventh one is feedback. We have various checklists for these four steps. I will be showing these checklists towards the end of my video. So the third and most important step I discussed here was the communication with the patient and the family member. So how do we communicate with the patient or their family members about their prognosis? So we have various tools to aid in communication. We have spikes models for communication, for breaks and giving. So among this, the most commonly and most used one is spikes protocol. So spikes model is S stands for setting up. So we have to arrange a private room or privacy space with minimal interruptions, and we make them to sit comfortably. After that, the perception step comes. So spikes, the P stands for perception. So we have to ask the open questions like what do they know about their disease status first. So that is perception. What do they think about their disease? And the I stand for invitations. So we ask the patient what they would like to know, like complete diagnosis and detailed prognosis. Will they want to know that? Like that, we have to ask. And the K stand for knowledge. That explain the disease in a clear manner. The complete diagnosis we have to explain them in a clear manner. That is knowledge. And E stand for emotions. So we have to address the emotions of the patients once we set the diagnosis, and we respond with empathy. And the S in spike model stands for summarize. That we just need to recap and decide what is next, and we have to assure the patient. Next is breaks protocol for delivering bad news. These are also same as spikes models only. So first we have to. I'm not going through details of this. First we have to set up the background of the patient. Background like setting up in the spikes protocol. Then we have to build a rapport with the patient or relative and explore what they know about their disease status, and we have to announce the current disease status with them and ask the patient to recount what they know about their disease status, and we have to summarize and assure the patient. So same as ABCD protocol also for delivering bad news, we have advanced preparations and build a therapeutic or environmental relationship with the patient or the family member, and communicate well and deal with patients and family reactions and encourage and validate emotions. So in all these protocol tools for tools to aid in communication, I said one step as empathy. We have to empathize the patient, or we have to address their emotions. So how do we need to address their emotions? So for that also we have one mnemonic. We response to emotions of patients. Okay. We have one tool for nurse for to address the emotions of the patient for caregivers. This nurse mnemonic for expressing empathy, we first N stand for name. So in this we have to identify the underlying emotions in a suggestive manner only. Like it sounds like you were really frightened when you got that news. Like we have to address like that only, and we have to understand the situations of the patient they are going. We have to confirm that we understood what the patient is feeling by discussing their experience and listening actively. Listening actively, we have to listen to them actively, and we should not think what we are going to tell in next. We should not think that, and we have to respect their respect the situation they are going through. We have to give verbal and non-verbal evidences that their reaction is very important. Then we have to support them, and like we should tell them like we'll be with them throughout the journey of their disease, and explore them. So means the patient will have questions regarding their future treatment part and care and the side effects of the treatment, etc. So we have to address all the queries that belongs to it. So whatever the communication behavior we have to avoid while we communicate. So we do not overload with the information, and we don't distort the truth. And we don't give false reassurance to the patient, and don't feel obligated to keep talking. Right? And don't withhold informations, and don't assume that you know what is concerning the patients, and never ever criticize and make judgment about the patient. Coming to the next, advanced directives in the context of end of palliative care. So, advanced directives is a legal document in which a person can express what kind of medical assistance he or she wishes to accept or refuse in case he or she no longer able to decide about his or her own care. So we have three forms of this advanced directive. The first one is living will. So a living will is nothing. It is expressed as a list of preferences referred to medical treatments that the patient should or should not receive in certain potential situations. And the next one is durable power of attorney. It is a document in which the patient names another person to make decisions when he or she is unable to do so. So that agent is also called as healthcare provider. And the third one is informal statute of preference. That is written or oral statement that specifies the patient's preference as a whole, but does not address specific treatments or illness. So, very important point to note in this patient has the right to make change or revoke an advance directive at any time and inform the physician of his or her choice, which must be placed in the medical record. Coming to the last part, the dispositions. So, how do we dispose patients from emergency? So, we have hospice references. So, in inpatient hospice unit, where patients can be directly admitted, provide a good option for care and rapid disposition if available at your hospital. We don't have this in-hospital hospice referrals in our case. And hospice referrals can be made from the ED for patients with qualifying debilitating illness, such as dementia with sepsis or stage 4 cancer with poor performance. But we have hospice centers near us, like Shanti Avaidana Ashram in the Safdarjung enclave, which is very near to us. We can refer the patients there. And Akash Hospital and Hospice Care are there, and Dr. Gaurav Chana. These are all in Delhi only. So, end of my topic, take-home points are the primary goal of palliative care is to relieve suffering. And the palliative care starting in the AD is to help patients and their families focus on their goal of care. So, the clinician must evaluate the disease trajectory and overall function of the patient to help guide further treatment options. Most people want to die symptom-free in familiar surroundings. It may be possible to manage the symptoms and arrange the transition back to home from them. If the family still cannot take care of the patient, additional help should be arranged for an alternative place to live while the patient continues to receive hospice care. So I would like to conclude my presentation with a short message. Dignity in that is a birthright of each. Showing how do we assess the Maynard scale.
Hello, Mr. Clem. Mr. Clem, how are you doing? So, as you can see, Mr. Clem is exhibiting noisy labored breathing, and that will score him a 2 on the Maynard scale. Next, you can see with his vocalization, he has an occasional moan or groan, and that would score him a 1 on the pain app scale. Hello, Mr. Clem. Mr. Clem, how are you doing? So, as you can see, Mr. Clem is exhibiting noisy, labored breathing, and that will score him a 2 on the pain app scale.
If the patient is expressing noisy breathing, it is
Next, you can see with his vocalization, he has an occasional moan or groan, and that would score him a 1 on the pain app scale.
so here the patient was occasional moans or groans, so it is scored into 1.
The next thing you can see is his facial expression. He has quite a facial grimacing going on, and that would score him a 2 on the pain app scale.
Facial grimacing was present, so we scored into 2.
Next is body language. As you can see, he has rigid fists, and they're clenched. His knees are pulled up and being pushed away and striking out, and that would score him a 2 on the pain app scale. Finally, consolability. As you could see when I first walked in the room, he was distracted or reassured by my touch, and that would score him a 1 on the pain app scale.
So the last one was consolability, so it is he reassured by the touch, so it is scored into 1. So here in this video, the total score was around 8, so it is severe.
ಎವ್ರಿ ಮಂತ್ ಬ್ಲಡ್ ಟ್ರಾನ್ಸಿಷನ್ ಮಾಡಿಸಬೇಕು ಮಗುಗೆ ಅಂತ ಹೇಳಿದ್ರು. ಪ್ರತಿ ಸಲ ಬ್ಲಡ್
This was the guidelines for the end of life care by AIDS. For this, we have the step 1 was the recognition of utility of further management, and for the second step is I have said already this clinician's consent. So in that part, I have mentioned you that consensus should be documented. Why, for what reason they have given the consensus of the on what basis they have decided the futility, we have to document here. We have to certify the treating physician. And we have various communication checklists. These are all the checklists. So if the patient is competent to take medical decision or surrogate decision making, and this also we have to explain them. And the step 4 to 7 was completely checklist based upon the checklist. So these are all the checklists for that. Checklist for initiation of end of life care. So this was the continuous assessment of daily supportive care plan checklist. In this, they have assessment of physical symptoms and the clinical decision making and medications we have given to the patient. And nutritional status of the patient. And in step 6, we have documentation of the daily progress plans. Step 7 was the feedback. not do it. Now the problem is how to initiate this, how to integrate palliative care. So this what availability of uh, so after that we discussed a lot of things and we have prepared a module. We have prepared I think the process is three or four parts. First thing we have prepared a module of 2.5 parts that we will be able 6 monthly we can flow that module 2.5 hours to 7 so what is exactly the technique of palliative care and how integrate palliative care in emergency. Plus, what are the communications? Communication may actually people come only by practice, but there are certain rules. जैसे वैसा भी देखो उसके protocols बनाए हैं. But if you communicate properly, मेरे पास automatically हमारे communication आ जाते हैं. So वो communication का अगर हम 1.5 hours, 2.5 hours, 1.5 hours, just demonstrate that communication is difficult. Plus 1 hour how to integrate with the person with the second thing what I am proposing that the problem ये आती है कि बहुत सारे डिपार्टमेंट से लोग आते हैं जैसे एमएस के डिपार्टमेंट ऑपरेशन पेशेंट को तो एग्जांपल जैसा कि दिया है बहुत आसान है इंटीग्रेट palliative care करना ऑब्जेक्ट बनाना आई विल टॉक विद and I will try convince them that they should keep giving only the supportive care and they should not do anything wrong. So it is important that how so what we can do by saying that any patient who are coming once we will be all trained how we can do. We should have one page which is color in the file of the patient who are there are two patients and it's and they are coming frequently to emergency and we are doing the same thing symptomatic management सबका करना चाहिए. तो इसके बाद कैसे हम उसकी प्लानिंग को एम्पावर करके उस पेशेंट को वापस घर ले सकते हैं प्लस उसको ये पता है कि सिमिलर सिचुएशन दोबारा आएंगे तो हाउ वी शुड हैंडल इट and what should be the what is the what we are doing consolability I can do the kind of life care policy को बनाई थी वो almost 95% patients and 95 ऐसा नहीं है कि सारे 95% मॉडल लेकिन even ऑडिट मंथली रिपोर्ट palliative care ward इनके दूसरे अगर बच्चे वार्ड है तो एक पेशेंट की रेसिडेंट में और किसी के एक तो सारे पेशेंट को क्या करते हैं there's all the family members and send them home and send them home करके और उसके बाद पेशेंट को ऐसा नहीं होता कि we are at home and we are empowered with no problem आती है because one number is emergency number they need to the president to call and it is compulsory to attend that call. अगर वो पेशेंट की कॉल की जरूरत है तो वीडियो कॉल करो सेम को ऑडियो कॉल करो but it is compulsory to just cannot miss that call because you need to follow that number or out of hours or any type of medical similar kind of thing like हमारे पास कोई भी पेशेंट आएगा तो उसको हम एक परफॉर्मर बनाए कि वो these are the bigger factors in end stage heart disease or lung disease and we have started discussion of our aim will remain on the supportive care not and इसके अंदर बहुत सारे लोगों को इन्वॉल्व होना पड़ेगा लाइक कार्डियक डिजीज में डॉक्टर संदीप से बात न्यूरो में तो सारे लोग ही रहते हैं सर न्यूरो को काफी पल्मोनरी में एवरीवन so we can talk to these people that whenever such patient will come we will create a performer that we will fill up that we have given supportive care simultaneously we have discussed the end of life care or end of life care नहीं बोलोगे तो भी हमने possibility of care from the discuss कर दिया I discussed this in our automatic protocol. Each patient talks to the so otherwise हमारे यहाँ हर एक एक्सपो में डालते हैं एक्सपो में डालते हैं पता हो जाएगा कि हमको ये पेशेंट एक सर्वाइव करेगा तो किसी साथ में रहेंगे और जरा गरीब इसकी पड़ जाता है सोचता रहता है कि कैसे बेड हो गई मेरे वीडियो प्लान से सर हर जगह अपना आईसीयू बेड ढूंढता रहता है कितनी ज्यादा चीजता रहता है कि उसको जितना बेस्ट से बेस्ट कर सकते हैं समझाने वाला ही नहीं कि आईसीयू एट टॉप क्लास के बेस्ट है एंड हमारे आईसीयू बेड पर 50% ऑफ आईसीयू बेड से ये अगर हम गवर्नमेंट सर्विस में इसका थोड़ा ज्यादा मौजूद है बट एटलीस्ट 10 to 20% of आईसीयू बेड आर नाइन unnecessary occupied and people are used to bed of patient. So I think
Just a few observations. Patients who came to the get some testing. What do they do?
सर इसमें भी इसका एक आंसर है सर जो टर्मिनल और मेलिग्नेंसी वाले पेशेंट को जो गैस्ट्रिक कंडीशन आते हैं उस समय अगर वो किसी ने भी पहले तो दैट वाज द रीजन पहले स्टार्ट राइट टू द बिगिनिंग तो अगर किसी ने एक्सप्लेन किया हुआ है कलर परफॉर्मा तो करना होगा अगर ऑन्कोलॉजी वाले की डाले लेते हैं पल्मोनरी वाले की डाले लेते हैं ऑलरेडी बट अगर ऐसा नहीं किया हुआ तो उसको भी अगर इंटीग्रेटेड मैनेजमेंट किया तो कोई कम्युनिकेशन नहीं अदरवाइज अगर हम इंटीग्रेटेड किया तो कंसेंट हम लोग है ना कंसेंट में बहुत ज्यादा इम्पोर्टेंस है Many times 90% patients don't pay properly, they will say not. Oncology के साथ बना कर देते हैं तो बहुत सारे पेशेंट ब्रेक होते हैं कि हमको एक्सप्लेन करना होता है नॉट दैट ब्रेक इनफ if you are confirmed that intubation is not going to help, you should try to. So इस कंडीशन में देखो अगर की ऑटोनॉमी को सबसे प्रॉब्लम हो but it is because any transmission is going to confirm they should go to admit and if you see that it is just what we are doing at the protocol and our area or protocol is very otherwise so also important to consider it's completely important to tomorrow today I will give my consent and tomorrow तो कल को लगेगा कि नहीं सिर्फ मैंने इसमें ऐसा करते हैं तो इसमें नहीं करेंगे बहुत सारे पेशेंट clearly बोल देते हैं कि हम allow करते हैं but उनको ये नहीं बोल देते कि ट्रांसप्लांट का कोई also हम लोग consensus amongst all the caregivers is perfect. Utility consciousness is not silent. Then consensus amongst all the caregivers means primary physicians, family members, including nurses. हमारे nurses की कल बदलती रहती है, but बाहर के देखने को continue including nurses who are looking after them. Because what is your even in nurses, nurse is to the patient, so what is what comes to the keep on waiting. But everybody is with me and there are conditions. So there are no conditions. Finally, saying that I have not till the time family you are not sure that treatment is going to be the time, but in once you want to be sure and then you want to take nicotine and think about people like that how very about family who are there and family members are very good.
Now we can take that because you know gambling, most of the patients here are followed, but some patients like very illiterate patients are there who don't know what they're eating for. Just running on all the hospital, and one time they're present in a gambling case. We don't know initially what initially was he already in order to start CPR as soon as possible. While doing CPR, one person go and check. That time we will see some report or something that is saying this may be metastatic stage 100 or something like that.
Euthanasia is poor palliative care. Euthanasia, palliative care is not palliative care principle says that we will regard dying as a normal process, and we will not do anything to enhance death, but we will not do anything to prolong death. So euthanasia is not palliative. We are against euthanasia and we should not do it. Okay? But definitely, if patient does not need aggressive treatment, we should stop and we should try to take only support. And every patient should die with it. Unnecessary or incident that you that is also something that is there. इतना ज़्यादा मेहनत करते हो हमारे
Now we knew that our private that according to the but the leaders usually they have a better that once you are best we know first then the facility of care is better. But let's say during the CPR we don't have time to establish that consensus with the other consultants. So we in the evidence medicine let's say normal consultants.
तो ऐसे exceptional cases में धीरे धीरे ठीक जाओगे कि पहले तो खुद को you very sure that this is more than absolute and then you are sure that automatically all of the situations will start let's just say alone तो ऐसे exceptional cases में जहाँ पे कुछ भी पता नहीं है I think yeah सब कुछ पता है
When it is teacher, sometimes when you are actually doing it, there are chances that you get some injury yourself. You are trying to teach a thing. So if there is no benefit, there is stupidity of there, more than 10 minutes, please don't do it. There is no law which can actually say that there is something which is counterproductive to the patient loss it, you are like it, and you are not doing it. So in that condition, you are free to take the decision and you take the right decision that from any correct opinion.
In this case,
Yes, there are many ACM restrictions or malignant, scheduled malignant patients who are already intubated and already on ventilator.
and they are coming to
Or intubated and in the emergency currently. So any guidelines on withholding the treatment and extirpation of
So definitely ऐसे patient को जिसका already other oncology से आगे जो therapy है treatment is oncology treatment is not required immediately after that, कई patient होते हैं जो they are ready, अभी थोड़ी home की importance है ना that everybody should die at home. वो हमको सिखाना है.
Young child had dengue, and after that she had become dengue. So after that she was extubated on the way to the ambulance and she died. And the father actually filed a case against the hospital.
No, see, this is a very exceptional thing. And we child, I don't think that we should I don't think father को children and father children होता.
Father discussed
Father himself what?
to extubate the patient and send the home after the child home as declared as already there.
And उसके बाद what?
What case कर जाता है, and the doctor who extubated the patient was from DMC for
See, I think ऐसे cases से please disappoint नहीं होना है. I don't think that ऐसा again अगर वहाँ पे communication में कमी हो तो ये communication gap रहा है. There was some communication बहुत important है. And ये जो rare case बता रहे हो ना खड़े होके ऐसे cases आएंगे. And every day you will find. Even I can say in last 20, 22, 23 years, every patient अलग तरीके से communication की principle सीखना जरूरी है, but every day communication is and इसमें literacy का कोई रोल नहीं है. Literate or illiterate, everybody understands properly what one is saying. Anything to do with और भी कोई communication many court cases going all over the world. There is only one single reported sample that was the communicate properly नहीं है. और कोई reason ही नहीं था.
What madam is saying, the moral of the story of the today's lecture, beside all the guidelines and how to implement it, a good team approach, the trigger can be there from the ED. It is non-oncology cases are equally important, and we receive a lot of non-oncology cases for such care. What is very important is a communication. Like you do a lot of CPR, intubation, blocks, blah blah blah. But one of the key critical skills is communication, and communication has that actually is the moral of the story for everything. And we need to train ourselves in a good communication skills. And madam is willing to train us every 6 monthly. I think we can do have a 2.5 year module on this, and which is really be a big help. And maybe there is one of the key skills in your exam.
And what I
Communication skills.
रिलेटिव्स को डॉक्यूमेंट नहीं किया तुमने कम्युनिकेट नहीं किया तब तक तुम उसको करोगे बट इतना इन्वेस्टिंग नहीं करोगे तो उसको ready करोगे।
Thank you.